chaplain here at UCSF. And on behalf of the Spiritual Care Services and Dr. David Bullard, I want to welcome you today to our panel here of wonderful folks that David's going to be introducing more in detail. But what I do want to say is, in our world today, when we've always been aware that we are handed birth and death at the same time, and somehow we've trained really well around birth and acknowledging it, but we've kind of let the other side be a little bit more taboo and pushed to the back. I'm so grateful to be part of many who are pioneering, being much more open about how we die, choosing consciously how we approach death, being aware of death, and honoring that with the same kind of teaching and awe and reverence and even enthusiasm that we bring to birth. And so, without saying more, I want to just add that here at UCSF Medical Center, we do now have the NODA program in force. NODA stands for No One Dies Alone. I wouldn't be surprised if there were a couple of NODA volunteers in the audience. Anybody here volunteered for NODA? See? I see 2 hands going up. So what that means is here at UCSF, when there is a patient that doesn't have support of very strong measure at the end of life, then we have folks who are well trained to come and be present with them and sit with them. So all of these are aspects and indications that we are bringing the right attention to the issue of how we approach death. So without further, I'd like to introduce the wonderful Dr. David Bullard, and we'll take it from here.
Wow, so happy to see everybody here, because as you know, without ticketing in advance, we have no idea. And I just want to say it's an honor. This is my 40th year affiliated with UCSF. I started in a job with your parents' tax office in 1976, the same year I started my private practice, which was the same year Bill did. So apart from the academic and scholastic accomplishments, he, at least, and I have something in common about having been in practice for 40 years. I'm really honored to have this opportunity to be with all of you, and I'm going to introduce them in a moment. Talking about death is, we have to acknowledge here that for a lot of people in this world, death is tragic, terrible, painful, awful, just violent. And we're, in a sense, talking about the best possibilities here today. To do that, we have 3, to me, heroes. 10 years ago, I started attending a meeting at the Symptom Management Service, which is co-sponsoring this, which is an outpatient palliative care group here at UC. We're also sponsored by you guys with the Spiritual Care Services, and by California Institute of Integral Studies that Janis represents here in her program. She'll tell you about it. So, I think particularly, about 6 months ago, I had an opportunity to get to know Bill, Dr. William Richards, through Skype, doing an extended series of interviews for something on a psychotherapy network website, and it was just extraordinary to get a chance to meet him, talk with him, and find out all of what he's been doing in terms of the use of psychedelic medicine for a wide variety of purposes to ease human suffering, and he's going to talk a lot about that. B.J. Miller has been a member of our Symptom Management Service group as long as I can remember, and he's also got the TED Talk, which you probably have seen in the advertising. It's now up to closer to 5.5 million hits on having a good end of your life, and meanwhile having a great time being alive as well. This is the first opportunity to bring them all together with Janis Phelps, who's got this training program she'll tell you about, the first of its kind in they're needing to train people who will be available for the phase 3 clinical trials for things like psilocybin and MDMA for people with death anxiety, existential anxiety, and a lot of other issues. So I think without further ado, I'm going to have the 3 of you sit down and just have a conversation. This is the first time the three of them have been able to talk substantively this way together, and we're privy to that, and I really appreciate that. They're heroes of mine, as well as all the frontline people, and many of you are, working in palliative care, healthcare, who are in the forefront of looking at human suffering. It can take its toll, I know, on many of you, and hopefully we'll hear how these people have dealt with it over the years and their suggestions for all of us to live more joyfully. So let's welcome Bill Richards, E.J. Miller, and Janis Phelps.
So, thank you so much for being here. It's my privilege to be the one to start the ball rolling. And what we thought we would do is the microphone needs to work first. It was left on lock, but then he turned it down when I left the room. Yay, okay. See, things go forward well when there's teamwork. So, happy to be here, and it's my job to get the ball rolling. We'll have an open conversation with all of you for the last 30 minutes of this opportunity to be with one another, but we'll start out by my initiating discussion by Bill Richards with you about the work that he has done with people at end of life for, we calculated, 50 years was your first session back in 1967 at Spring Grove Medical Facility in Baltimore, which he'll tell you about. We're very lucky to have Dr. Bill Richards here with us, so I'll turn it over to you, Bill.
I think I'll stand up. Thank you all for being here. It's an honor to be here and to be with my hero, BJ, and Janis. I feel like I'm dreaming, you know, this is a little too good to be true. Yeah, back only 50 years ago when I first gave a psychedelic to a terminal cancer patient, about that time, actually Walter Pankey and I wrote an article called Implications of LSD and Experimental Mysticism. It was my very first article. And I remember we closed it saying that one of the greatest dangers associated with psychedelics might be losing out on the benefits that the positive, responsible use of these substances could provide. And then, of course, psychedelics went into the deep freeze, and 17 years ago at Hopkins, the rebirth began, and it's been expanding. And now we're at a very hopeful place in dialogue with the FDA and the EMA in Europe, and it looks like it's quite probable that within 5 years, maybe less, maybe a little more, that psilocybin will come off Schedule 1 and become prescribable. And now people are saying very practical things like, if this happens, how are you going to manufacture enough psilocybin? Who's going to implement all this? You know, clearly we know that it's more than a drug effect. It's not like just giving a medication to someone. It has to be in a context of profound trust and positive motivation, courage. And so there's a need for skilled guides, therapists, Sherpas, whatever we're going to call them. And who are they going to be? Are they going to be the psychiatrists, psychologists, social workers? Are they going to be pastoral counselors? Are they going to be a specially certified group of people? I keep going back to the hospice movement and Cicely Saunders, back when I did my doctoral dissertation, which was a study of DPT, a substance very similar to psilocybin in cancer patients. At that time, The only hospice in the world was Cicely Saunders' place, St. Christopher's in London. She was one idealistic lady trying to improve the way people die. You know, and now Medicare pays for a hospice. We have hospice organizations, training. Why can't that happen with psychedelic treatment and research centers as well? You know? And it looks like it may really be happening. So maybe some of you will be among the first to legally implement this form of treatment. This treatment, intervention, I'm not sure what we should call it. Just to make sure we're all on the same page, I think everyone knows that there's no such thing as the psychedelic experience, but there's a vast spectrum of experiences, and these drugs give access to this spectrum of experiences from, you know, mild sensory changes, kind of the tie-dye t-shirt effect, that really doesn't do anything either way unless you're artistically inclined. And then there's psychodynamic experiences of getting into your guilt and your grief and your anger and your interpersonal relationships and sorting through all those powerful dynamics. And then there's this realm of visionary archetypal experiences where people experience gods and goddesses and precious stones and things that are incredibly, profoundly, personally meaningful to people. And it's so remarkable because that level of experience often is unanticipated. It's different from what you grew up with in childhood often. You know, so the good old agnostic has the vision of Christ, and the deprived addict from the inner city has visions of dancing Shivas. And, you know, many of us feel that this is empirical support for Carl Jung's concept of the collective unconscious. That within us, there really are incredible resources that we're just beginning to discover. And then there's this thing called mystical consciousness. With sufficient dosage and a lot of preparation and support, but there's incredibly beautiful, meaningful state of awareness of unity and intuitive knowledge and kind of feeling at home in the universe in spite of death and suffering. And you can imagine that when that happens to someone who's close to physical death, that's an incredibly helpful experience. And what's so remarkable is that with psilocybin, you don't have to keep giving the drug. That what's curative is the memory of this state of consciousness. It's not a typical psychopharmacological effect. So in our studies that were published on December 1st, that we are very proud to say were covered on the front page of the New York Times. It was a group at Hopkins and a group at NYU in New York, and a group of 80 altogether. And generally 80% of those cancer patients had significantly reduced depression 6 months after their experience. You know? I mean, there's nothing like that in psychiatry right now. That an experience can be facilitated that's so powerful. And so as we move with the FDA now into phase 3, we're concentrating on treatment of depression, both with cancer patients and people with major depression who don't have cancer. And maybe 3 years from now in the New York Times you can read our results. But that's the final step towards making it legal, at least in the United States. we're doing on time.
Good, 5 more.
5 more. I can tell you on a personal level how profoundly meaningful it is doing this work. I was just remembering this first patient I treated 50 years ago. I feel like it was yesterday, Like I still remember that patient vividly, and the others. Everyone is so unique, and the family dynamics are so unique. And the challenge is to develop an incredibly deep rapport with a person in a very brief period of time in order to ensure safety and efficacy. The one type of experience I didn't mention are so-called bad trips. The only real bad trips are experiences of confusion, paranoia, panic, and they happen when people aren't prepared. It's a bit like, in my book I mentioned going skiing without any preparation. You just jump on the skis and go down the hill. Chances are you're going to injure yourself or someone. And similarly with psychedelics, there needs to be some knowledge of how to navigate in the inner world, how to confront difficult material, how to trust, how to take this leap of faith, whether in an institutional religious context or another more philosophical context, but this willing to relinquish control and kind of dive into the unknown. And what's so remarkable is that in these transcendental states, the deeper one goes into the unknown, if you will, the more familiar it becomes. And you get these reports over and over. Well, I've been here before. I'm at home. All is well. Julian of Norwich, all is well in the universe and all matter of things shall be well. It's not necessarily that the person is convinced of personal immortality, though sometimes people do have that conviction, but it's just like in spite of all the suffering of the world, everything still makes sense. And so it becomes possible then to live fully until you die. As I'm fond of saying, just because you're mortal is no reason to be depressed. Most of us are mortal. And it's amazing in these families how the patient who receives this form of therapy often becomes kind of the social worker for the family. Who it's the patient who opens up communication, who talks about the taboo topics, and who teaches the family how to laugh on the last day of life, and then kind of savor the moments right to the end. And, or, if you want to look at it spiritually, Teilhard de Chardin does say we're all spiritual beings having physical experiences right now. If you take that perspective, then what is death? Tolstoy in The Death of Ivan Ilyich has this wonderful concept that as Ivan is dying, all of a sudden he can't find death anywhere. He says, death, where is it? Can't find it. In the place of death there was light. So in that framework, perhaps death is simply waking up. It's not that big a deal. But that doesn't mean that we all want to run out and commit suicide. Because life itself is treasured. And so you squeeze all the goodness out of each day you can. You accept the medical treatments that make sense. And you reject perhaps some of the experimental treatments that don't make sense, And you enjoy your relationships. And if this could really be integrated into hospice and palliative care, the whole way we approach dying in the Western world could change. So we'll have some discussions.
That was just a taste of the richness of Bill's thinking, but it's well thought out in this book also. I have 10 copies here, so 10 lucky people come on down at the end of it.
You make it easy because you're a hometown local hero, nationally known, globally known. He does not need an introduction to you, does he? Dr. B.J. Miller will speak to you about his understanding of what he's been all about in his life in light of maybe some of what Bill just said, but not required. So take it away.
Janis. Man, Bill, when you get moved, the whole world is. Look at your face. I met Bill in D.C. not that long ago, and it was the most moving experience to hear him say these kinds of words, but more to watch his face. So anyway, thank you, Bill. And I love thinking about your career. I love thinking about how you came upon this beautiful salve for the soul, and how the world kind of turned on it, and you stuck around and kept at it, and here the world's come back and caught up with you in a way. Pretty beautiful. And there's maybe all sorts of messages for us in there too, to sort of stick with certain things that we know to be true, even if the world's telling us that they aren't. So, gosh, to add. I'm coming at this conversation from a couple different angles. One, I think, just to pick the most narrow point of view, just as a clinician, as a palliative care clinician, I sit with patients and we do this thing. We go through pain, anxiety, depression, all the things that we know that can get in the way of a gum up person. But very often, you're left at the end, having gone through that list, and everything's checked off, and you're still aware that you're sitting in front of someone who is in some crisis one way or another. It doesn't qualify for pathology, and therefore for our drugs. But there's something else going on, and we can't put our fingers on. And in medicine, in clinical and palliative care, we call this existential distress. It's sort of a catch-all term just to mean, a deep pathologized anxiety that we don't really know much about and can't fix. And I would say over the years of doing this work, my sense is that this diagnosis of exclusion is probably the most common diagnosis ever to walk into a clinician's office. Not just palliative care clinicians, I mean even surgeons. That this crisis of needing or feeling connected, or this perception of feeling isolated or alone in the world, is rampant, despite evidence to the contrary. It doesn't much matter if you don't feel it. So to pick one angle, I'm sitting here, I'm interested in this subject because of this, just as a clinician. I want to know what can I do when I'm sitting in front of that issue. And today we really haven't had much to offer. And then, of course, as a human being, as a fellow person, as a fellow patient, as someone who also feels isolated at times and removed and awash in meaninglessness, etc., I'm interested for my own sake in where I can go with it, what I can do about it. I mean, I know enough from my own experiences of being injured that, and being close to death, that I know enough to know that we don't know everything that's known. That's known. We don't know everything that there is to know. We in medicine, we in healthcare. So that's another thing that's driving me here, is some embrace or acknowledgement of the world beyond our beakers and our test tubes and our randomized controlled trials. Some of that's, and I don't even think that's a statement of faith, there's more going on. I think that just feels empirical to me. And as a patient, I remember just trying to find a way to make sense of what had happened to me. And, if I was honest, if I thought about my life before my injuries, it's not like I felt so great. It's not like I felt so connected and hunky-dory. Even though all the criteria for one to feel hunky-dory I had a roof, I had a loving family, I had an education, I had male white privilege, I had, everything. But it didn't necessarily make me feel so great. So it was actually some getting close to death myself that allowed me to feel that connection, to realize that the variations on the themes of suffering, there's variations that we all suffer, that we all die, and these were uniting forces, and that also that they weren't necessarily even bad. Like if I realize all that I've learned from my suffering, I do not wish to have not suffered. But what would I do? I would be, it would be half a life to have absence of those lessons. So I guess what I'm pointing to is this sense of mystery, and when things that are out of control, and this sense of not belonging, that's an interface. That puts us up against something very big and very beautiful, very mysterious, and something that impacts all of us. And it's that sort of total inclusivity that really compels me clinically and as an individual, and and delivered me to this seat in search of something that Bill has been researching for a long time. So we could go on and on about that, but maybe I'll stop there because I think what would be really exciting is to get a more conversation going and hear from Bill.
I think I will follow in Bill's footsteps and stand, since you're a large audience, and I'm taking just a couple minutes before we then, the three of us, have a conversation upon which then you'll ask us loads of questions. I'm here as a clinical psychologist. I'm not quite as long as you two in my practice, but it's been 35 years. I just did the math when I said that. And I've been a professor of clinical psychology for 30 years. And I'm at the point in my career, which really happened maybe 15 years ago, is that I became rather despondent about the ways in which somatically based and talk-based therapies are really helping people. And I didn't really know where to turn, except I'd had in the back of my mind my knowledge before things got scheduled. I'm old enough to remember what the possibilities were in the old days. So as things began to open up here in this country, with the advent particularly of the Johns Hopkins studies back in the early 90s, and then moving to UCLA, NYU, New Mexico, I began to have hope. And I was tapped 2 years ago to create the first accredited certificate program on psychedelic therapy for training of doctors, nurses, therapists, clergy people, marriage and family therapists. Who am I leaving out? We have naturopaths in our cohort to train them to be able to do what Bill was so inspiringly talking about, that in several years, we're quite convinced if all goes well politically, things have been going well, incredibly well empirically, that all of us in the room who may or may not be licensed, but those of us particularly who are licensed, ordained, or commissioned, we will be able to sit with people utilizing psilocybin while they're passing. We may even be able to allow family members to partake. We may even be allowed to build teams among ourselves of the caregivers by utilizing psilocybin in FDA-approved studies ourselves. And that's what CIIS, and I'm hoping other universities will collaborate with us and do the same, is train a whole cadre of people in this country that are needed yesterday to be poised to help do this work. So our focus is really, bottom line, it's not so much clinically, we're after bettering the wellness of people. And we think if we could help demonstrate that it's there's other ways to die with dignity, both for family members and the patients, that people will begin to see there's other possibilities for the use of these medicines for post-traumatic stress, addiction reduction, OCD, cluster headaches. There's so many opportunities for us to explore that we haven't been able to yet. So I'm very happy to be sitting among these two renowned folk while they speak to their understanding of the work, because I'm following in their footsteps, supporting their work. So people who in this room are younger than me, who'd like to do the same, there's a path we're bearing ahead of us, because I know everyone in this room who's doing palliative care knows what burnout is like. You know what it's like. You know what dreading that partner or child walking into that room after having yelled at the charge nurse and they're coming at you because they're not ready to lose this person who's dying. And you just are so fried you can't help that person, and you so want to, and you take it home. We think the work we're talking about can help you all and your deathing process and the deathing process of the people you love. Mycelium. So I'm standing here with great hope, and I'm really glad to be here with you two, because I think we can open it up and talk about, I don't know, whatever you want to. We thought we'd talk about what brought us here, where we see the field going. You and I talked a little bit about that, but I'd love to hear what you think. And then we open it up to what you all want to talk about. But I believe, David, we have about 10 minutes of a dialogue here. Okay, so what do you want to talk about?
Oh, you got an idea, Bill?
You know, we talked a lot about spiritual development and psychological development, for that matter. And enlightenment is certainly a gradual process. Self-actualization is a gradual process. And I sometimes wonder if it's possible for us as human beings to be aware of essentially two worlds, you know, a temporal world and an eternal world. World of time, relationships, and a realm of ultimate love and beauty and meaning somehow. And kind of move back and forth or incorporate both ends. Could that be the evolution of our species? You know? For us to, you know, if depression is basically a narrowing of consciousness, of forgetting who you are, of losing your connections with other people, you know, well, what meditative disciplines and psilocybin, for example, are providing or offering is an opening up of consciousness, you know, reconnecting with important people, letting love flow, letting forgiveness happen, being able to be creative again, even if your life may be limited quantitatively, you know? You know, it sounds like the old testimonial, but we literally had one woman who was lying in bed, bedridden, because she had cancer after all, you know? Preoccupied with her pain all day, complaining all day, who literally got out of bed and danced at her daughter's wedding, you know? And often people are acting as if they're disabled when they're really not. They're just stuck in their depression, you know? And especially if time is limited, why waste it? You know, this is the time to be living most fully. So it's a whole new way of thinking in some ways, but I'm very hopeful.
That makes me think about, so I think a lot of people enter the healthcare system when something's wrong. Something's gone wrong. And so we see our job at most to mitigate suffering, to make things less bad, less horrible. And if you can do that, that's a beautiful thing to offer. Mitigate suffering is no small thing. But it's also true that we can be agents, or that even suffering is part of the route to this sense of awe and wonderment, and life being actually really amazing and remarkable and mysterious and strange and beautiful. So I hope, part of what I hope is cracking open, two things come to mind as you're talking. One is that healthcare see itself, medicine particularly see itself on behalf of something larger, that health is not the end point, that somehow connection, quality of life, you might say, or some well-being, that's really maybe what we should have. Maybe we should lift our gaze behind just life being less junky, less crappy, less hard, less, and that healthcare, again, that medicine would see itself on behalf of something larger than itself. And all the humility that goes with that, and all the creative connectivity that can come with that. So for me, one of the things that's exciting about this subject is this pulls us to that precipice. This pulls us to this interface between suffering and well-being, this interface between medicine and the rest of the world, this interface between what we understand and having some ability to touch all that we don't understand, and somehow not be as afraid by the stuff we don't understand. Somehow be turned on by mystery and curiosity. That's what I feel like we're on the cusp of, and and psilocybin in this way, psychedelics in this way, are emblematic of this larger cracking open. That's my hope.
Oh, I'm so with you on that. I would add in our knowledge of environmental degradation happening now, and genocides across the planet, and general malaise that we talk about quietly at the cash register with people at the drugstore, or over coffee with our friends, and then sometimes not at all. And can we measure that with our objective measures? No, but we all know what that's like. I feel like what we're talking about is so imperative. How can we come together in larger communities of heart and showing up in the present moment? Will our mindfulness techniques and yoga that we do in our living room really pay off when we get out on the street? We're really not showing up for one another as humans yet, not fully enough. And boy, does it show in the deathing process. It's tragic. It's tragic how we are. So I really love what you were saying earlier, Bill, around the being in the two veils of being present and being aware of the mystery. I think that may be our next train we're on in consciousness. And we in this room know something about that because we're sometimes midwifing people walking that edge. And I'm very much hoping in expanded access opportunities in a few years that we could explore how to be more present with one another, how to bring more love into the room. Love, the four-letter word that we get taught in our medical schools and graduate schools not to use too much or only in certain ways. We've got to get over ourselves. It's time, if not now, when? So I find these medicines are very helpful in grounding people, bringing them back to their earthly bodies, getting in their bodies, be present. They catch a glimpse of that mysterious familiarity that Bill was talking about. I think that is curative, but it's not for health. It's that beyond place BJ was talking about. Let's go there together more.
It reminds me that sometimes it feels like, as you were talking, that one of the ways we get comfortable with death, if we do it all, is we fetishize it. And we do that. Like there's sort of two ways to go. You can devalue life so that death doesn't matter that much, which I think is sort of a norm, violence and all this stuff. But what a shame. The other route would be, the bigger challenge would be to love your life while you have it, to appreciate what you have, and know that there's something beyond this body, something beyond this life. And even if there isn't anything beyond this body, beyond this life, just to take a skeptic's view, shouldn't kindness and beauty and love be their own reward anyway? So I don't know where I was going with that. It's not a social critique, but it just does remind me that, so we do deal with that in the way the dominant theme is to devalue life as a way of getting used to the fact that we die. I guess our creative challenge is to love life all the more because we die.
You all might know of a couple Buddhist practices where you contemplate death. When I first learned this practice, I didn't get it. I thought I was learning to die gracefully. But what the practice did was it taught me to love my life more, simultaneously with the anxiety about dying go. And I was an agnostic when I was practicing this. It had nothing to do with knowing what gives. The intimacy of feeling well was nurturing in of itself.
It's interesting that the people who seem to respond best to psychedelic therapy are often, they can be skeptics, they can be agnostics, but they're open, they're curious about life. They're willing to experience something. There's kind of a sense of adventure, you know? Yeah, I'll experience something and then I'll decide, you know, how metaphysically valid it may be, you know, or what it means. But there's this courage, this openness, and just as an attitude towards life. I think the people who would have trouble with a psychedelic session under the best of circumstances would be anyone who kind of wanted to prove a point, you know, a really die-hard atheist, or someone who believed the 27th Baptist Church was the only way to heaven, you know? But where there's a sense of openness, curiosity, trust, willingness to dive into the unknown, these incredibly meaningful experiences happen. Sometimes there's personal suffering, like the road up the mountain may take you through some unresolved grief and some guilt and some, you know, it's not all fun. I often like to say if people just want to have a good time and get high, psychedelics are the wrong drugs. But if you really are interested in personal and spiritual growth and you're willing to experience some discomfort in that process, then they can be very valuable under the best circumstances, of course.
Would faith come up a lot, the question of faith?
Faith, not as, I like to distinguish between the act of faith, i.e. diving off the diving board when you don't know how deep the water is or what the temperature is, you know, versus the content of faith, you know, specific religious creeds, whether Christian or Buddhist or Muslim or whatever, you know. Creeds are fine, but it's not the letter of the law, it's the spirit of the law that comes, you know.
Everything I hear makes me wonder why is this only done in the context of death. See what positive is of this, why just not do it that much earlier before when you was faced with that.
Will you repeat what he said?
So I think the question has to do with, I don't know, why contextualize this around end of life? Why wait? Is that right? So I'll speak to that for a second. I'd love to hear you guys.
So it takes several seconds.
Okay. One is, I think there's a permission, the end of life allows, well, if you're dying soon, there's a sort of, there's a laxity that can creep in. We can allow ourselves to go a little farther, think a little different, get a little things that you wouldn't do, like you can have a cigarette at the end of life in a different way than in the middle of your life. So there's this sort of ethos of permissiveness that is maybe strategic as a way to begin. And I think also this subject matter, that anxiety and angst, this sense of meaning and belonging takes on super significance when you realize time is limited. If I had all the time in the world to figure this out and touch into it, then perhaps I wouldn't be so anxious. I'd get to it. But that fact that there's a finitude strikes the demand a little bit. So but I think just like in the field of hospice and palliative care, so many people go into this field, so much attention is at the end of life, but you don't start, 5 or 10 minutes goes on by you're talking about death before you realize you're really talking about living. And so the whole field has had this inductive experience. Start at the end and work backwards. You know? and that's kind of the context of a lot of the field's work too. So there's a few answers to your question. I'd love to hear from you guys.
On our ride down, we were having conversations about what exactly happens with the psilocybin for a person who is dying. And you haven't been very specific. You've said amazing things about a very large process, but can you be more specific about what it is that occurs that relieves the anxiety, the fears, that makes that a passage, that journey that we don't want not to have the journey, but what happens?
Wonderful question, thank you. Like, why, what is it about psilocybin experiences that it's helpful, you know? And of course, it depends on what type of psilocybin experience is occurring to some extent. But let me speak to these deep, transcendental, mystical experiences that seem to be the most potent and the most valuable. We get the best, longest term reductions in anxiety and depression after these so-called mystical states of consciousness. I think a part of it is that this mystical state, if you will, whether it's a big delusion or not, you can debate, but it feels intrinsically self-validating. It feels more real in this state of consciousness. And when people remember it, there's just a kind of an inner peace, confidence that goes with that memory. And within that state of consciousness, there is what the Hindus call the net of Indra, or in Christianity we talk about the brotherhood of man, or the unity of humankind. There's a sense that somehow we are all interconnected within consciousness in the great unity. And that gets rid of estrangement and loneliness. Like you really know that somehow you're part of humanity, you know? The pure beauty of these experiences. I mean, we can dissect a lot of brains. And we can't find these diamonds of the self anywhere, much less dancing Shivas. But we honestly don't know what we are yet. We don't know what consciousness is. But we're all pretty sure that there is such a thing, right? You know, even at night, we dream, you know, what's going on, you know? Where do these mental images come from? And especially in psychedelic states, some of these abstract, multidimensional geometric patterns, mandalas, unfolding visions of the Christ and the Buddha that are just so awesome. Where do they come from, you know? We don't begin to understand, you know? We can say, well, there's a little more circulation in this part of the brain, and that's great, you know, let's do all the science we can, but correlation isn't causation, you know? That consciousness especially if consciousness is ultimately atemporal. We don't know how to think without time and space and cause and effect. You know, the categories that we function with don't apply to these mystical states. And so one aspect of determining whether a mystical state has occurred is whether the report includes ineffability. And then invariably it says, I promise to write a research report and I want to be a good research subject, but this is ridiculous. There's no way I can put this into words, you know? But here's a few words anyway, but don't take them too literally, you know? And there's also what we call paradoxicality, that when people try to talk about these states, it sounds like they're contradicting one another. You know, I died, but I was never so alive. Ultimate reality was one, but it contained everything that is. The great emptiness was full, you know, okay? And on and on. And you can say, oh my gosh, that's just nonsense. Or you can say, this is the human mind trying to express a both and orientation instead of either or. And it's beyond the current limits of language, you know? So this isn't only great stuff for psychiatry folks, this is great stuff for religion and philosophy, and maybe even scholars of the Divine Comedy.
I'd like to ask something of the room. This is brilliant to hear you do it. And he has spent 8 hours describing to you what he just did, and he just gave you a nugget, so hold it. I want to ask you, after he's done this, when you heard Bill talking about those characteristics of experiences, can I see a raise of hand of anyone who as a child felt something like what he was talking about? Doing whatever you're doing. Can you raise your hands higher? Wow.
Anyone
I'd
not?
say that. Yeah.
Anyone
That's
not?
it's a significant hand raising in the room. So let's just pause here. We're talking about something that's endogenous. It can come out of our mindfulness work, it could come out of singing, it could come out of ecstatic sex, it could come out of being in a psilocybin session with two beautiful people sitting there witnessing you. There's something implicitly healthy about these moments, and let's stay really curious about what those moments are. Yeah, serotonin's involved, but it doesn't explain it.
Could you guys describe for a group what a session looks like, just the mechanics of a session?
Oh,
Gladly. Yeah, the way we work at Hopkins, which is the tradition before and in other sites, really. You know, there's screening, medical exam, all that, basic data collection, and then there's usually 5 to 8 hours of relationship building with the guide. And then when the day for psilocybin administration comes, we have this very pleasant kind of living room sort of environment, a nice white couch with some beautiful art on the wall and a good stereo system and a couple comfortable chairs for the two guides, usually a man and a woman. The person takes the psilocybin capsule after usually putting some family pictures around the room and kind of making the space theirs for the day.
tell me about the rose.
Yeah, and there's a rose, of course. The tradition of the rose goes way back to treating alcoholics in Saskatchewan, but it's become a kind of a tradition when I think every center that gives psilocybin has a single red rosebud. And when you come out from under the eye shade and headphones, let's say to go to the bathroom or to interact with the environment, it's it's a nice transitional object to kind of meditate on for a few minutes. And often it opens up like in time-lapse photography, and you feel you can dive into it, and it's a very beautiful experience in itself. We also have a bowl of grapes, which is also for the co-therapists. but in other words, it doesn't feel, there's no white coats and stethoscopes in the room, unless they might be needed for a medical emergency, which we're prepared for with our IRB, but it's never happened.
Never.
Well, there was one time I'm aware where blood pressure got a little high, and we gave some nitroglycerin to help someone. Not because they were in danger, but because our agreement with the IRB was that if blood pressure got beyond 160, we would administer nitroglycerin. So, very conservative guidelines. But, we're working in a medical school, and we want to ensure safety, and we want to be conservative. And yet at the same time, there's this knowledge that psilocybin has been used by Indian tribes in Central America, Mexico, for probably at least a couple thousand years. Ayahuasca, which contains dimethyltryptamine, is used in Brazil. The Native Americans have been using peyote, which contains mescaline, for probably 5,000 years. And nobody ever takes their blood pressure. Actually, the safety profile, the physiological safety profile, is really very high with these substances. We would screen out anyone who had a brain tumor, a really acute cardiac condition, serious renal problems. And again, not necessarily because the person couldn't benefit potentially, but because within the context of a research design, we don't want to take those risks. That's kind of a separate research project. And but the main psilocybin, all the major psychedelics are non-toxic, they're non-addictive. So the danger, insofar as there are dangers, it's from either impurities in the substance, improper dosage, or its lack of preparation and guidance of knowing how to respond to the opportunity in a constructive way. If you take the drug and wander through a shopping center, chances are you're not going to have a very good experience.
Janis, I wonder if you could address that earlier question and give a brief overview for those who don't know that across the bay in Oakland, starting tomorrow, is a 6-day conference that's sold out with almost 3,000 participants.
Yes, it's the Multidisciplinary Association of Psychedelic Studies, which has been in existence since 1985. I think this is the largest turnout ever had. The major researchers in the United States, and many have come from Europe to speak about their research, most of which are the double-blind, randomized controlled studies, but some are also in what's they're calling a plant medicine track, where we'll talk about the use of ibogaine and ayahuasca and peyote and other medicines over the millennia, and the cross-hatching of that with the sacredness. You probably caught a bit of that, the ceremonialness of what's done, for instance, at Johns Hopkins, as Bill was describing the rows and the setup. So unfortunately, people can't get tickets now, but it's being live streamed. So I would recommend you take a look at it's at www.maps.org. And Bill and I will be speaking. There's a few other culprits who are speaking in the room, one of whom I'm looking at. Can you raise your hand if you're speaking at MAPS? So these folks will be out and about. You have some unsung heroes here. Maybe we should ask if anyone from UCSF who just raised their hand would like to say something. I asked you to raise your hand. Would you like to weigh in on anything you've said? Yeah.
I'll just stand briefly. Hi, my name is Brian Anderson. I'm from the psychiatry department. I'm on the team that'll be starting a psilocybin-assisted psychotherapy study here within the next few months for long-term AIDS survivors. I just want to thank you both, or all three of you, for speaking today and for bringing your knowledge to UCSF, how you have. We will be taking referrals for our study soon, not quite yet. Yeah, we'll be presenting a little bit at the conference. If I can ask a question, I would love to know what the panel thinks is important for people who want to train to do this work as far as having a meditative practice, a contemplative discipline that they're trained in order to sit with people dying, whether or not there's psilocybin involved or not.
Oh, well, let's see here, Brian. I think I would, in terms of setting aside the question of standardizing, and sort of judging one's contemplative experience to qualify you. Putting that aside for a second, I guess I would say that if I were to distill that question down even further, I think it is somehow demonstrating the capacity to sit with suffering and to not flee from it. So I think that would be the effect that I would hope a meditative and contemplative practice would instill in the provider. So how to sort of judge that and how to gauge that and standardize that, I don't know. But I would say that I have to imagine that a piece of this experience has a lot to do with who's guiding me, and to take that piece very, very seriously. That it's not just about the drug, or even remotely about the drug per se. So it'd be interesting to think through how to prepare guides. That's the right word.
It's a good word.
Yeah. So, but I do think that there needs to be rigor around that. I think that would be ripe for exploration. It'd be interesting to say, do the guides have to have had an experience with psilocybin in order to guide one through it? Probably. But some ground for empathy and sitting with suffering and not running away and having a stillness before a storm, I think would be important.
Yeah, I kind of feel the most important characteristic of the effective guide is presence, and the next word would be patience. You know, to just be able to be with someone in the present moment without having to ask what's going on every 2 minutes, you know, without interfering, being there if needed, but not being in the way if you're not needed. That's the essence, and I wouldn't say everyone would have to have psilocybin training experiences, though I can't think of any better way to train people. Actually, when I worked at Spring Grove, Maryland Psychiatric Research Center, it was on-the-job training. When you were hired, you got 2 LSD sessions. And we wouldn't allow you in the room if you hadn't had your 2 LSD sessions. You know, because there was the feeling, in order to have empathy and be sensitive, you needed to have some knowledge of these other states of consciousness. Now, you can also obtain it without psychedelics through, if you're lucky and disciplined, through meditative practices or all the other ways that these wonderful states of consciousness open up to people, sensory isolation and flooding, and for those women who are fortunate enough, and sometimes in natural childbirth. But I think you have to have some intuitive appreciation for mystery and transcendence. Otherwise, when the person starts getting into altered states, you just wonder, is he going to lose control? Is he getting psychotic? And you start getting anxious. And if you start getting anxious, it's contagious, you know? So the guide has to be able to remain centered and just go into your own meditation if you're not needed.
We actually objectified what you two are talking about a wee bit in our interview process for the physicians and nurses that we let into the program. We have 7 questions for a long interview, and this gentleman gave us the 2 best questions, I think. This was 2 years ago when we were talking. We asked them what their goals are and why they want to be in the program, etc. Easy ones, and then we asked them next, tell us about a time in which you had a dark night of the soul. How did you relate to yourself while you were going through it? And how did you relate to others while you were going through it? Who did you reach out to? And what did you learn about yourself while you were reaching out to them? Looking back on that dark night of the soul, what did you learn from it? What meaning did you make of it? And that has been, more than any question we asked, the deal breaker for whether we let someone in the program or not, because it shows their capacity to be with not knowing, how contemplative they are, how much they're willing to dive into the deep end, into the unknown, regardless of their spirituality or religious background. And then we ask them, when have you yourself been in what you would call an alternate state? Where were you? Were you on a vision quest? Were you making spaghetti? What was it like for you? So those of you who raised your hands, we're looking for people like you who had some kind of experience you can identify as that which brought you back to some home base within yourself. And you're willing to acknowledge it as a truth within your own being, ineffable as it was. We don't really care how many years you've been a therapist or a physician, although that helps. But there's a lot of unlearning that needs to go on, I think, in order to do the kind of sitting we're talking about. You're letting the process unveil itself. So I agree with what Bill was saying. We are hoping, and with some encouragement from Brian and Bob up there, to develop protocols so students and hopefully current researchers will be able to have MDMA and psilocybin in an FDA study in which they will be one another's sitters. So they'll learn to be a guide sitter, and they'll have the experience, and they'll know what they're talking about. So we're working on that now. MAPS has already developed an excellent protocol for that, for their therapist training program with MDMA. So there's lots of really good things afoot. You pick.
I'm just wondering about like clinical settings and in terms of the guide and the setting, is that happening like in a psychiatrist's office, or is it something that the patient could say, well, this is where I feel most comfortable, or because I know setting has so much to do with it. Is it something that could happen outdoors, or what have you?
Well, right now, since we're in specific research, implementing specific research designs, we want to hold the setting constant. And so, we at Hopkins, we have 2 windowless rooms with a nice painting of a natural scene. The best window we can come up with. But actually, when you have the eye shade on, the room really doesn't matter all that much. Yeah, in the research and retreat centers of the future, why couldn't they be in some beautiful natural setting where, especially in the latter hours of a session, you could wander outside with a trusted companion and commune with nature a bit, Right now, what's important is that the setting provides confidentiality, safety, physical as well as psychological safety, and is is acceptable to the institutional review board, frankly. You know? And it sounds prudent, you know? Yeah.
Yeah, question here.
So with the psilocybin therapies, and gives you that openness and interconnectedness, do you use that to help with end-of-life patients? Do you help facilitate family abuse or trauma or post-traumatic stress for them at the end of life to help them get through the passing?
Well, we like to stress that it's not only having the experience, but it's the integration of the experience. And of course, we're limited by hours of clinical time and research designs, but we always offer at least 3 integrative hours and then follow up at maybe 4 months and 6 months, you know. But so you have often these insights, and then you need to apply them. You know, I haven't talked to Aunt Susan for 40 years since she didn't behave the way I wanted her to at my daughter's wedding, you know? And should I contact her before I die or not, you know? And yeah, well, yeah, maybe this is a good time to do it if you want to do it, you know? Yeah, I should really get around to revising that will. Yeah, it's a good time to do it, you know? Let's face up to it and do it, and so on. But to some extent, the integration of these profound experiences is a lifelong process. You know, whether life is a matter of weeks or months or decades. I'm fond of saying it's not only what am I going to do with this mystical experience, but what is this mystical experience going to do with me? You know, and I think there is in many people a gradual increase in compassion, in playfulness, in tolerance of diversity. I don't know for sure if they kill less bugs or not. I would be surprised, you know. But there are kind of behavioral, attitudinal changes that gradually seem to unfold from these experiences.
Maybe we could say one little small thing in answer to your question, but on a sidebar about risk mitigation. We all know in the 60s and 70s when safe settings weren't really known and certainly weren't universally utilized, there was a lot of fallout where people didn't get anything close to what Bill was just talking about. One of the next steps and edges in this whole field is to look at how to teach people who are out there recreationally using these medicines, not knowing what they're doing, and teaching them about what we're talking about here, that it's not for fun. These are serious ways of being in the world that come to you if you do it in community with understanding. And there's a lot we can do in this way, but I feel we're at the edge of where needle exchange programs were, or condoms for teenagers were back in the day. That does it look like you're aiding and abetting, or are you actually doing public service? There's upwards of 1 million people a year using a recreational psychedelic or psychoactive substance every year, new, virginal, relatively unschooled on how to do it well. We owe it, I think, as a medical profession, as a mental health profession, to help those people as well. Were you going to say something?
I want to give Don a moment here.
Question too. So.
Yeah, well, you're allowed a question, but this man just wrote a fantastic book that was released yesterday called Changing Our Minds.
Thank you.
And stand up a minute.
Yeah, my name is Don Latin. I worked for many years at the Chronicle. Some of you may have seen my stories in the Chronicle. I've had a wonderful adventure as a journalist and a participant observer in the last 2 years going all around the country and the world, interviewing researchers like Bill and people like Janis, and research subjects, neuroscientists, and as a journalist and as a participant observer. And I put together this book called Changing Our Minds, Psychedelic Sacraments and the New Psychotherapy. It's a pretty, if you're interested in the overview of this whole new wave of both medical research and spiritual exploration into beneficial uses of psychedelics, there's a chapter on the work at Johns Hopkins that Bill's done. There's a chapter on some work with end-of-life patients with MDMA that's being done just over in Marin County, Phil Wolfson. There's a chapter on addiction. There's a chapter on ibogaine, which is really helpful for some people. This horrible epidemic we have of opioids and heroin addiction. So I interviewed dozens of people over the last couple of years, and ordinary people, neuroscientists, and I also wrote a little bit in the book. It's not about my trip, but I suffered from depression for a long time, and I was searching for an alternative to antidepressants, normal antidepressants. And I went all the way from a Swiss neuroscience lab to the South American jungle, and found an alternative treatment that worked for me. I experimented with MDMA, ketamine, psilocybin, 5-MeO-DMT. The question that I had, though, Bill and Janis, is, we hear so much about MDMA and psilocybin in all these clinical trials, but there are many other substances. You mentioned LSD, which hardly ever gets mentioned. A lot of the early research was with LSD. You mentioned the sacred plant medicines like ayahuasca, ibogaine. Why is it that we're focused so much, you think, on MDMA and psilocybin? Those two, there's dozens of different substances that are out there. And why is the MDMA good for PTSD in particular, and the psilocybin for end-of-life anxiety and depression, or what? Is that what we're trying to figure out with the research, or just why those two drugs are kind of the leading edge here?
Psilocybin, let me talk about psilocybin first, has many advantages. It has a long natural history of use by Indians, good safety record. Its duration of action is 6 hours at most, where LSD is at least 8, if not longer. It works into the clinical workday well. Psilocybin takes you right to the most productive area of working, the most intense part, certainly 45 minutes, an hour in, where LSD builds up very gradually. You don't get to the productive period until about 3 hours in. So you're just kind of sitting there waiting, LSD evokes incredible responses, either irrationally pro or irrationally con. It's just a hot potato in the press, in the mind of the culture yet. And there's a feeling, let's get one drug off Schedule 1, Psilocybin is really the best candidate. A wonderful thing about psilocybin is that it's hard to spell. There's LSD in that other drug. And it just doesn't get the press. But there, not only is there psilocybin and short-acting derivatives of psilocybin, CZ74 and CEY19, and there's DPT and DET and DMT in different forms, and there's LSD, and there's MDA as well as MDMA, and so on and on. And chemists are creating new molecules every day, I'm sure. But I think it's wise to concentrate our research efforts right now on psilocybin, and to have many universities demonstrating, investigating potential uses, and documenting efficacy and safety. And let's get psilocybin accepted, and then we can move on. MDMA, I'm not an expert in MDMA, but my impression is that MDMA kind of opens the heart chakra. It's good for marriage counseling, dealing with post-traumatic stress. Psilocybin seems to more open the thousand-petal lotus, if you will, you know? And the noetic, what William James called the intuitive knowledge of these mystical states, seems more likely to happen if the dosages are right. But they're both, we're talking about diamonds and rubies here. You know, they're both incredibly valuable substances if we use them wisely.
Let's end with that word wisely. And the good news, bad news. The bad news is we've come to the end of our time for this conversation. I want to thank all of you for your participation and your interest. The good news is, if this has whetted your appetite, number one, for what BJ likes to talk about, we would have had him just do his TED Talk, but we didn't have a room that fits 5.5 million people. But I really recommend it. It's amazing. I listened to it again today on the way over here. And Bill's book, which I heartily recommend, is so rich and full of not just about the medicines that we've been talking about or about research or clinical work. It's really about life. And he's with 2 master's degrees in theology, and I have 0 background in theology. It was very wonderful to read this. And finally, to thank Janis for your participation here. And now all of you know why these are my heroes.
We have all my brochures here.
Pardon?
Notes on the piano. Brochures. My marketing material.
Yes. Yes. There are great brochures up here from the CIIS program. And Don is going to have his books, and we're going to be over here selling the books, and you get free stuff over here.
Brochures over there, books over here.
Thanks so much.